that's
C'est la vie.
Yeah. All right. Good afternoon, everyone. We'll get started. Thanks for coming. I am Ankur Barija, faculty here in geriatric medicine, medical director of the inpatient geriatric programs at Stanford Hospital, and have worked with a lot of you in the inpatient side. So thank you all for coming. A lot of familiar faces, and this is our inaugural geriatric medicine grand round. So thank you, Marina Martin, for helping us out. Our section chief in geriatric medicine, Taylor, for all the logistical help, and really excited to invite our introduce our speaker today, Dr. MacLullich. Okay, almost. Got
Perfect.
it. So he is a professor of geriatric medicine from University of Edinburgh. He's an international expert in delirium for many years now. He founded the European Delirium Association and is a past president. He's very active both in the research and clinical space as far as delirium is concerned. Is passionate about new detection and management approaches to delirium in the acute hospital setting. Also credited for creating a new tool for delirium screening, 4AT tool, and has published 100+ papers in peer-reviewed journals, and active in orthogeriatrics and acute geriatric medicine at the hospital there. We're really happy that he's here today in our conversations. There was a lot today about multidisciplinary approach to delirium assessment, detection, management. So I'm happy to see lots of colorful, very colorful in terms of multiple disciplines, clinicians and others. So I'm really happy to see that. So hopefully it'll be a nice Q&A session afterwards. Looking forward to it. Thanks again for coming.
Thank you. Thank you so much, Ankur. It's a real delight for me to be here. I didn't know it was the inaugural, so I feel even more privileged also to come to a university like Stanford. My old friend Jose Maldonado, a professor of psychiatry and an expert in delirium, is here to offer me some moral support, I think. But we had a really nice lunch yesterday, and I've loved my time. And my first ever visit to California, actually, I was at the American Delirium Society earlier in the week, and have really had a great time. And I'm missing my kids, and I'm glad to be going back to see them, but I'll certainly miss my time here as well. So my talk today is a clinically focused talk. I'm going to start with just some orientation around, just so we're all on the same page about what delirium is, and then I'll be speaking mainly about detection and then on to clinical care. And just one important caveat is that delirium as a field, even though it affects a staggering 1 in 8 at least hospital patients globally, it's a field that doesn't have a massive amount of research, especially in the treatment side of things, which I'll come to. So a lot of what I'm saying is opinion. It's derived from my own clinical experience. It's derived from my reading of the available literature and from expert consensus. So I really hope that I will be able to have discussions about some of these opinions. I've already in the rounds this morning seen that there are practice differences. I mean, one of the big differences between the UK and the US is that we have a lot of geriatricians. Like in my hospital of 1,000 beds, we have 140 geriatrics beds, and we have, at least 20 geriatricians at the senior level working, and it's just normal for geriatrics to be embedded in the hospital system because it works, and I hope that will eventually become the case, here as it is in the rest of, the industrialized world. But, I can see also that the delirium program here is very evolved. It's been around since 2013, and you're doing things with a small number of geriatrics people here and other colleagues that we're not doing, even in my own hospital. So I'm taking back some inspiration from that. So I'll just kick off with I think a good place to start is with the patient. I think we should always be patient-centered. I used to find this quite an annoying phrase. I thought, well, I am patient-centered, I hope. But actually, reading about it and thinking about it more, about autonomy, about remembering the person in front of you as just being like you or me, but just in a different position, and being kind and trying to put yourself in the shoes of people, I think is a very important principle which we can always get better at. So if we take this lady living at home independently, some memory problems, but basically would not be described as having dementia because her functional status is good. She has a broken hip and comes to hospital. And a very familiar situation to people here, that her son comes to visit her and finds that she is not right. She's changed in some way. And she's changed in two ways that this case illustrates. First is that she is confused. So she's become cognitively impaired more than before. And also that she's developed the emotional disturbance of this. She's also developed, in relation to that, a delusion. So this is a typical kind of case of delirium. So this is a sort of general definition. I'm going to get to DSM-5 in a minute. What is delirium? And it's quite a simple condition in some senses. It's when somebody rapidly changes its mental functioning, which is triggered usually by some kind of acute illness, a drug side effect, trauma like a hip fracture. Sometimes we don't find a cause. And it's distinct from dementia. I probably hardly need to say this, but I think it's important for me to emphasize this, not so much for you here, but for people that you teach. Because I've found over the many years that people are persistently confused about the difference between delirium and dementia. And people just haven't had enough training about that. So it's really important to emphasize the difference, that it's not the same because of its rapid onset. Often it's transient, and the severe attentional deficits are worse. Now, the DSM-5 criteria, which probably are the criteria that most people would say are the ones that we should aim for or adhere to, cover attention and awareness in criterion A, and a change over a short period of time as the essential two diagnostic features. I'm going to be speaking about criterion D shortly. I want to emphasize as well that delirium is not just a cognitive disorder. It's a disorder, as I said in that case, which involves many dimensions of mental status change. So people are often sleepy or very agitated. People often have psychosis, probably in up to 50% of cases. And there are many other features too. So it's a complex condition. And reducing it just to cognition is a mistake, because then you don't understand the patient properly and you can't act. Another important issue about delirium is it's the terminological chaos that has bedeviled the field for many years, with seriously somebody thought that subacute befuddlement would be the... So imagine if I was just telling you there, I was very pleased to come to the United States from the UK and enjoy my time here, and I've just come out of the American Subacute Befuddlement Society conference. So, but there are other terms that are used. I'm hoping that we're just going to dump all of those terms and just stick to the word delirium, because that's what ICD says, that's what DSM says, that's what the patients need to hear. They don't need to hear about 6 terms for what they've got. They need to get a consistent message. These are some, on the right column, these are some terms that are sometimes used to describe somebody with delirium. And there's nothing wrong with using those terms, but they are just a starting point. It's not the end. And I think we owe it to patients to come up with a diagnosis, because that then gives them, as Wes Ely famously said, he's a famous intensivist and delirium researcher from Vanderbilt, that once you get the word delirium in your notes, once you've documented it, delirium, not subacute befuddlement, not encephalopathy, not toxic psychosis or any of that crap, but actually the right word, delirium, then they get a ticket to the brain dysfunction camp. And then they get in there, and then they get, people who know what they're doing helping them out, instead of a vague diagnostic limbo. So that's important to get the term right. So just as a quick recap, delirium is a really common condition, as I say. Somebody told me there's 500 beds in this hospital, is that right? So That means that about 80 people in this site now have delirium. 80 people. I don't know how many people are in this room. Probably slightly more than 80. But you know, this number of people, roughly, right now have this condition in this institution. And they're struggling, and they're going to do badly. They're going to have higher risks of bad outcomes, which I'll come to. Older people are much more vulnerable to it. It's very common in ICU, and it's very common in dying patients. Certain groups are much more vulnerable to delirium. I think that's everyone here would know that, but just to emphasize that older people, people with dementia, people with comorbidities on multiple drugs are more likely to get delirium. Now, over the last 15, 20 years, a lot of very important work has been done to try and understand the consequences of delirium better. And unfortunately, it's not the transient and benign condition that people used to think it was. Like, people being dismissive of delirium, saying, you know, it's inevitable or old. Of course, they get a bit confused. You know, that's what do you expect? You know, or it'll just treat the pneumonia and it'll go away. You know, and you don't have to do anything for it itself. That's just wrong. Okay, those perceptions are mistaken. And we've moved on from that scientifically. So I think we need to discard that and now treat this as a serious acute syndrome that requires a professional approach, a technical approach that involves diagnosing it and then taking it seriously and going through a lot of steps to do well. And the reason is that lots of severe consequences. Now, there are acute consequences like severe distress. People with delirium get more pneumonia, often because they're drowsy and they aspirate. They often get dehydration because they don't know what they're doing with a cup. Just they tip it over, or they forget that they're thirsty or don't feel thirsty. So we need to take care of those basic biological functions that are not being taken care of because their brain isn't working. And then there are longer term consequences, which I've listed there. One of the consequences which and I mentioned about being patient-centered, that we have missed, I think, even delirium experts have missed. I'm ashamed to say, and this has only come to my awareness in the last few years really, is just how awful it is for someone to have delirium. Maybe somebody's writing that on a sheet now in Stanford. It's possible, isn't it? This was written by a patient with delirium in an ICU without the nurse knowing. It's a case report that was published. Just somebody wondering what was going on. And there are lots of psychological consequences from delirium, acutely because it's horrible, and then later on people, especially in ICU delirium, get PTSD fairly commonly. And Pratik Pantharipandi in Vanderbilt tells a story of one of his patients who was so shaken up by her time in ICU with delirium that she was phobic about going anywhere near Vanderbilt University Medical Center and died within 2 miles of it for years after it. She would just take weird detours just to avoid being anywhere near it. So this is a serious psychological condition, serious psychiatric condition which hurts people badly. And we need to diagnose it and we need to look out for the distress part of it. So now I'm just going to have a couple of quick slides on pathophysiology. I can't really cover it in any detail, but just to sort of bring you up to date with some of the ideas around what is happening in the brain during delirium. This very simple cartoon just sort of shows the process of something going wrong peripherally, something happening in the brain, leading to confusion, so cognitive disturbance, other mental state disturbance, and a delirium. And yet, to understand this scientific problem is difficult, as you can imagine, because you have to characterize all of this, work out something about what's happening in the brain, which is really hard to do with maybe EEG or imaging or CSF analysis or behavioral measurements, and so on. So it's a difficult problem. That's one of the reasons why we haven't made a lot of progress on delirium pathophysiology. So Jose Maldonado here, professor of psychiatry at Stanford, is the leading scholar and theorist, I would say, on delirium pathophysiology. And this is the latest of a long series of detailed models to try and integrate the many different disparate findings from animal studies, from biomarker studies, from imaging, into a way of trying to look at domains of dysfunction which have been implicated in delirium and how these might lead to failure of integration of the brain, which I think makes a lot of sense. You know, that the brain is unable to process online sensory information in a meaningful way, and it gets mixed up with memories or dreams and ends up with behavioral disturbance. And I think acute brain failure, although I'm advocating in clinical practice to use the term delirium, I think it's a reasonable description of what we're dealing with. So I can't obviously, I don't even understand these papers sometimes, but I can't really go through it all, but do have a look at this article here if you're interested. Zooming out from that level of detail, I think it's quite helpful from the clinical point of view to talk about two broad categories of how the brain might be affected such that delirium is caused. One is just direct brain insults, and I think we shouldn't forget about this. We don't need to have elaborate models necessarily to deal with the fact that if somebody's swimming in morphine, then the brain isn't going to work very well, or if they're deprived of oxygen, then it's going to affect the brain in lots of different ways, and the solution is to give them oxygen or to stop giving them so much morphine or give them naloxone or something. So direct brain insults is a fundamental part of understanding delirium pathophysiology. It's not necessarily all that sophisticated. However, we all see patients with delirium who've got normal temperature, pulse, blood pressure, oxygen levels, glucose. We don't even necessarily have a serious illness that you can find. What's that? You know, that's the unexplained bit where Jose's model, you know, attempts to try and understand, well, what are the causal chains here? So again, I can't really go into this, but it's a very interesting field scientifically if you're motivated to look into it. You know, one of the leading researchers in this is somebody called Colin Cunningham, and what he's done in animal model work is take animals with prion disease that's been induced, and these animals are in midlife indistinguishable from controls. They have some neuropathologically, they have some microglia that what Colin Cunningham describes as being primed. So they're a bit more activated, but not necessarily doing very much because of the neurodegenerative pathology in the brain, which looks a bit like the pathology you get in Alzheimer's disease. But what Colin's done is give a tiny dose of lipopolysaccharide peripherally, and that swims around the circulation, communicates with the brain, and then the microglia produce more toxic cytokines and cause more damage to the brain than in control animals. And this leads to a short-term disturbance in behavior lasting a day or two, and then the animal recovers, but later its trajectory of decline is much faster. Doesn't that sound like what we often see in clinical practice, that, you know, a pneumonia or a bad urinary tract infection and somebody with dementia, they're never quite the same again. So that's trying to understand the substrate and potentially leading to some therapeutic interventions in the future. So another important aspect of delirium pathophysiology research has been how delirium is definitely linked with a much higher risk of future cognitive impairments, acceleration of existing dementia or new cognitive impairment. This is a study I was involved in, led by Daniel Davis in Cambridge and now London, published in JAMA Psychiatry. And this found that, yes, controlling for baseline cognition, delirium is associated with more rapid cognitive decline, but especially in the presence of existing neurodegeneration. This was a post-mortem study. So in summary, I don't really believe that there's a final common pathway. People used to say that, like cholinergic transmission or something. That's just not true. There's too many things. You know, you take, you know, an antihistamine, that can't be the same as, you know, a traumatic brain injury as the cause of delirium. It's an absurd idea. You know, there are multiple ways the brain can go wrong. There probably are some important mechanisms that keep happening. So I think the therapeutic implications of this are quite important, though. This concept, I don't think there will ever be a time when we say, here's delirium and here's a drug for all delirium. It just doesn't make sense to me at all. Why would you do that? So morphine makes you delirious. Do you give a drug for that? No, you take the morphine away. You know, I think their drugs have a role in delirium for some aspects of delirium, but not as a general kind of treatment for a binary diagnosis, yes or no. So now I'd like to go on to the more clinical aspects. So I'm just showing these again to now think about the issue of reduced arousal. So let me just get this video to play. How do I minimize this? Okay, I'm not used to Macs. We need a bit of sound here. It's working before. It doesn't really matter. I think what's happening is that the doctor, this is an actor, by the way, the doctor is trying to wake this lady up. She's saying, Mrs. Wilson, can you open your eyes? That's all the dialogue in this little vignette. Okay. So is that familiar to you, that kind of scene? Do you get patients like that? So people who can't speak are quite common in medical practice, aren't they? People who just don't, they might open their eyes a bit. They're not in a coma. They respond a little bit to verbal stimulation. And one of the major problems in delirium assessment in the past has been the reliance on cognitive testing to diagnose delirium. That's been a serious mistake, in my opinion, because a good proportion, actually even up to 10% in some studies, of people in hospital are very drowsy and can't do things like even say their name, you know, or certainly can't engage. And that has meant that lots of times people have been doing tests, they've just scored them out and said, UTA, unable to assess, and the patient's not ended up with a diagnosis. That's been a major problem. And we've abandoned that problem now, thankfully, because in DSM-5, it clearly states that when people who are unable to speak and engage but are above the level of coma, that is called now severe inattention. You don't need to do a cognitive test, and that fulfills that criterion in the diagnostic criteria. So just as a quick reminder that we're not just dealing with level of arousal and attention in delirium. There are multiple things that can go wrong with the brain when people are sick. And I want to talk about some of those as we go, as well as the course, the onset and fluctuation. And most tools focus on the diagnostic criteria, acute onset, fluctuating course, inattention, arousal, and they cover these other aspects less. I'm going to come to that in a while. I'd like now to step sideways and talk a little bit about tools. Now, it's a bit bewildering if you're approaching the field of delirium and trying to understand why are there so many tools, what do they all do? It's a bewildering thing. Actually, most of them aren't suitable for clinical use because they were developed for research, so they've got a specific role. And when you decide to use a tool in clinical practice, and remember there is a wide choice, so it's not necessarily one choice that you have to make. You can actually look at literature and think carefully about what's going to fit with your needs. What is the purpose of it? And earlier today we were talking about surveillance for delirium. So if you're doing a test to look for delirium that might arise in a high-risk patient, that has to be a short and simple test that can be easily built into clinical practice, that doesn't annoy the patients with too much burden, doesn't take too much nursing time and so on. That's different from a screening test that is a bit more definitive. It's different from a severity test and so on. Many, many tools need training, and they need, if you've got rotating staff coming in and out of your unit, have you got the time to invest on a day's worth of training for every new member of staff coming through? It's expensive. Many tools actually require maintenance training. So after a year, you have to check, are they still able to do it, and so on. These things are all important factors. So I'm going to talk a little bit about the 4AT, which is a tool that I developed with 2 psychiatric colleagues in Edinburgh about 7 years ago. And I developed it because I had recommended the CAM, the Confusions Ethic Method, in the British Geriatric Society guidelines as the best available tool for delirium. And I tried to implement it in my hospital, but I'd struggled to implement it because we couldn't get training organized for every person who was using delirium. And also people found it too long and found it difficult. So reluctantly, because it's a lot of work, I thought, well, for my hospital, I will develop a tool that I can then recommend to people that's going to fit with the amount of resource and time that I have. And I'm just going to go through its features because it's probably not a tool that you're familiar with. So the A stand for alertness, AMT4, attention, and acute change. It's designed not to require training, and it's designed to be very quick. So I'm just going to go through each feature. So the first, by the way, a score of 4 or above, and it goes up to 12, is said to indicate possible delirium. It's a screening tool. So it's just it starts with arousal. As I say, I think that needs to be done, because if you ask somebody who doesn't know about delirium to start with a cognitive test and the patient can't speak, they often just stall. They don't know what to do next. They just say, oh, I can't do this test, there's no use to me, and they throw it in the bin. So that's why it starts with arousal. And if it's clearly abnormal, immediately it gets a score of 4, which indicates delirium. So that you can diagnose delirium in 5 or 10 seconds. And this is backed up by quite a lot of evidence now that if you're acutely drowsy, but not comatose, there's a well over 95% chance that will fulfill criteria of delirium. So it's a shortcut to delirium diagnosis. Acute drowsiness equals delirium, essentially, in hospital. Then it moves on to 2 brief cognitive tests, which are embedded within the 4AT. The AMT4 stands for the Abbreviated Mental Test 4. So just a 4-item cognitive test. You just ask the patient, what's your age? What's your date of birth? Where are we? And what's the year? And one of the features of the 4AT is this idea of untestable. So if somebody just cannot speak like that lady in the video, unable to say anything, they get a score, which is untestable. And if you get a score of untestable for that and for months backwards, you get a 4, which triggers the potential for delirium again. So an untestable patient is slightly less likely than a drowsy patient to have delirium, but it's quite strongly indicative. Some people with severe dementia do have a score of 4 from the untestables, but it's not so common. And the attention test is just months of the year backwards. And the final item is just, is there an acute change or is there fluctuating? So that's the 4AT. Now, I was recently just looking at all the validation studies of the 4AT. And since it was published this is the original validation study that I was involved in, but because I published it on a website just for pragmatic reasons so my colleagues in my hospital could use it, somebody went off and did a validation study without me even knowing about it. And it was quite a nervous moment when I found it on PubMed. Like, what's the results going to be? Luckily, they're quite good. With 100% sensitivity and 82% specificity. But it's now one of the best studied cognitive tests, delirium screen tests in the world. It's actually got more people have been studied doing the 4AT than the CAM now. Now, I'd like to talk about the CAM, which I know is embedded in your system here and also in Kaiser, where I visited yesterday. It's very well established, derived from DSM-3R. I think you're probably familiar with these 4 features. It's an algorithmic tool, so you need to have both inattention and acute change. And if they're both positive, then you have either or both of disorganized thinking or changed arousal. And I say one of the problems I had with it was that some people got stuck with inattention, especially before DSM-5 came out. They said, well, if I can't demonstrate cognitive impairment through days of the week backwards because somebody can't speak, I don't know how, what does that mean? Is that inattention positive? How do I score that? And there still remains a little bit of ambiguity about how you score that feature when somebody can't speak. Because that kind of goes into arousal then. Are they both then positive? So these are not trivial concerns because a tool has to be ergonomic. It has to be simple, it has to be obvious if somebody's busy. So, as I say, I'm not doing this to be provocative or to turn this into a fight between the two tools. It's just to give you the information so you can then understand that the 4AT is not a new kid on the block that's hardly been studied. Actually, in the 7 studies, it's had nearly 2,000, which is more than all of the studies that I could find in a recent systematic review, and it has better figures in the CAM. Now, we just completed a head-to-head comparison of the 4AT and the CAM. Now, I didn't want to do the head-to-head comparison, I just wanted to do a validation study of the 4AT, but the funder in the UK was the UK NHS NIHR, in a £1 million study, said, we want you to compare the two so we can choose which is the best for the NHS. So slightly reluctantly, I did it. So this is the study design. Basically, it's a randomized study, so people would be recruited and they'd have a reference standard and then be randomized to the CAM or the 4AT under exactly the same conditions with independent raters, a fully starred, compliant study. And these are the results. And this is the first time I've ever released these outside of the study group. So in these wings, the sensitivity of the 4AT was 76, specificity 95, and the sensitivity of the CAM was 40, and specificity 100. So that we'll be submitting that soon for publication. Now, some other tools. So these are tools that are done by clinicians, doctors or nurses or physiotherapists, or people who've got some idea about how to do tools. There are other kinds of tools that are done. One is the Delirium Observation Screening Scale, which is a nursing scale implemented widely in the Netherlands, scored at the end of a nursing shift, and basically 13 items are scored. It's a pretty good scale psychometrically. The slight problem with it is it takes a bit of time. It takes 3 or 4 minutes, which is a lot at the end of a shift, isn't it, if you've got a list of a long list of patients. The radar is a tool which is aimed at surveillance, and this is developed by a professor of nursing, Philippe Vaillet, and all the nurse is asked to do originally during a medication round, but not everyone likes that because it's distracting during the medication round, and maybe it's done at some other time when you're interacting with the patient. But 3 different questions, and if it's positive, then you proceed to do a tool like the 4AT or the CAM. This is an informant questionnaire, which is, that's it, that's the scale. Do you think has been more confused lately? And it's a very effective scale, because that basically asks, does the person have delirium? That's all it says, but it relies on there being an informant. And it does happen, doesn't it, that there is no informant and the patient's just lying there sleepy, and you don't know if that's a normal state. Usually it isn't. So I think you do need more than just this, but some people just use this, because it's ultra quick and very simple. Jose and colleagues have developed this, which I believe is about to be published. There's a pilot study, an initial study, and a validation study, which are in press. And this aims to take further. There's a prior nurse-based informant ones, because it's quicker, and also it's based on the latest diagnostic criteria. It's very fast, which I think is an important virtue, and it performs similarly, to the CAM, and it's also, I think, preferred. So it's something seriously to consider looking at, in my opinion. I'll certainly be seeing if I can try it out as an additional measure, because the 4AT is kind of designed to do it on admission and if you suspect delirium, but it's not really meant to be done twice a day. It doesn't have that design, whereas I think this kind of tool in high-risk patients could be done in that way. Now, in terms of what you do with a positive screening tool, I don't think any tool gives you a diagnosis. I think it's always going to be clinical judgment. I just want to make that point really carefully, that a positive CAM or positive 4AT is not a diagnosis. You need to have clinical judgment before you go ahead. So I'm just going to now talk about the fact that most of our tools focus on what DSM-5 require us to say are present to diagnose, but they miss lots of important aspects of delirium that are important in caring for patients well. So as well as saying that person has delirium, I think you need to understand what is that patient's delirium like, thinking about those different aspects which are mentioned there. And the point of doing this is because understanding the features of a patient's delirium change the way you manage that patient, don't they? So if somebody's very distressed, you'll change the way you treat them, as opposed to if they're just sleepy but not distressed. Here are a couple of examples. If somebody is distressed, there's lots of different reasons for that. It could be that they're in urinary retention and they can't articulate that they need the toilet and they're just restless and something is not right, I need help. Have you seen that before? I see it twice a week, you know, in my orthopedic ward rounds. It's extremely common, you know, or somebody is just missing their husband, you know, and they just need a reassuring phone call. That could be it. I don't know where my husband is. I don't know where my husband, I've not spoken to him all day. I don't know where I am, what's happening. So it might be a psychological thing that you can easily fix with a phone call. And you certainly shouldn't be reaching for haloperidol to treat urinary retention. It doesn't work that well. I've found if you inject haloperidol, it doesn't make somebody pee, you know, and it doesn't get the husband to the phone. So, you know, these drugs are, in my opinion, very much down the line, you know, when you've tried all these other things. Increased arousal also has other specific things that you might do, like be really careful at monitoring for falls risk. So now I'd like to move on to delirium treatment. Now, one of the funny things, before I put that up, one of the funny things about delirium treatment is, as I've said, in this hospital, nearly 100 people have delirium. That's true, that proportion is roughly true in any hospital in the world. Incredibly common serious condition, which doubles length of stay, increases risk of falls, mortality risk of new institutionalization, lots of things. And how many RCTs do you think there are of delirium treatment? I'm not talking about drugs, I'm talking about non-pharmacological, which is the mainstay of delirium treatment. There are 3 RCTs ever in the world, in the history of the world, for delirium treatment. I'm not talking about drug treatment, I'm talking about like the kind of delirium treatment that you learn about, which is treat the cause. There's only 3 RCTs ever. Here they are. Cole in Canada did a couple which involved a consultation with an experienced doctor and then followed up by nursing, monitoring, trying to implement the recommendations. No effect really. And Pitkala in Helsinki, Finland, really tried hard. They used comprehensive geriatric assessment. They looked comprehensively. In fact, Yoko Lorelai, one of that team, did the paper that found that in most older people, there's more than one cause of delirium. So they're very meticulous about finding the causes and treating them. And they did find some effect of reduction in severity of delirium, which is encouraging, but didn't really make a huge difference, and it wasn't classified as a positive RCT. There are 2 before and after studies as well, which are listed there, which showed some encouraging features, but of course you can't really trust in the same way a before and after study. So we're in this funny position where all anyone ever says about delirium treatment is expert consensus and common sense. But of course, my common sense might be different from yours. I've, you know, in ward rounds today and in Kaiser, I've seen lots of people getting melatonin. Now, in European practice, that would be considered odd, you know, that so much melatonin is being used, you know, even to prevent delirium. It's not evidence-based at all, but it's considered to be sensible. So it's common sense, isn't it? And it's perfectly reasonable from, if somebody, oh, they're not going to sleep, they're going to have a terrible time, you know, altered sleep-wake cycle is a risk factor for delirium. You can easily make up a chain of logic that leads you to the conclusion that you should give all over 65s at high risk of delirium melatonin, so they all have a nice night's sleep. You know, I can see that. You know, I'm not in any way saying that's wrong. I'm just saying it's interesting that there are just huge differences all over the world because we lack evidence. And that's a problem, isn't it? Because these human beings are trusting us to know what the hell we're doing. And we're just like, you know, let's try a bit of this, try a bit of that, you know. So if you look at the guidelines, they all say this. And in fact, I've just been through a long process because I'm writing a guideline from the Scottish Intercollegiate Guidelines Network, the SIGN guidelines, on delirium. The first one of the only national guidelines on delirium in the world. There's one in England, the NICE guidelines, and there's two or three others. But it's quite an unusual event to have a guideline coming out on delirium because it takes so much work. And that's why, you know, we've really looked into all the evidence very carefully, and all the great literature. So this is always there. This is sometimes there. Often the focus is on safety, though. Like if the patient's unsafe, then you use haloperidol, but not necessarily finding out if they're sad or scared. That's not often in the guidelines, which I think is a shame, isn't it? I mean, you wouldn't miss out pain in a palliative care protocol, would you? You would say, let's look for pain. And what is distress but psychic pain? You know, that should just be a mandatory part of any delirium assessment. Is the patient distressed, upset, sad, frightened? And then there's variable coverage of these common sense, bread and butter things that, you know, on a good day you might remember all of them. So we end up with this funny position of just a whole bunch of a cloud of potential things that you might do with delirium, depending on who you are, how much time you've got, what's your level of expertise. But there's nothing standardized about it, is there? I mean, not everybody will get an enema prescribed. Probably everybody with delirium should have an enema prescribed. So the nurses, if they discern that the patient's constipated, they can just give the enema instead of waiting for another thing to happen, another consultation to happen. Deprescribing, that should probably be considered in every single case of delirium. It's not always present in guidelines. If anyone's agitated, they should always get a bladder scan, shouldn't they? They should always avoid dehydration. People should be mobilized, orientated, fed. Sometimes. So anyway, do you understand my point? It's just this kind of chaotic picture. And I think that is a real issue with delirium treatment. So the solution is first to accept the fact that delirium treatment is difficult. Now, I'm a geriatrician, and of course I'm in favor of geriatrics, and I think that basically, given that at least half of people in hospital are old and many of them are frail, and geriatricians are the people who know about those people, along with our, you know, our colleagues and, you know, specialist nurses and so on, that every hospital should have, you know, like mine, you know, a good proportion of geriatrics beds and specialists in the care of large numbers of people in the hospital. So this kind of level of analysis, this detail, is inherent to geriatrics. Geriatrics is probably the specialty that's the most specialist at delirium care, and because it involves a mixture of all the complex medicine. So we'll know, for example, whether that benzoflumetazide can be stopped or not, whether that ACE inhibitor can be stopped, whether that antipsychotic should be given, you know, and so on and so on. All considering all the organ systems, which takes quite a long time. Even if you're quite experienced, it takes 20 to 30 minutes, I would say, to work somebody up properly for delirium and deal with all those different factors. So the assessment of delirium, its causes, what is the delirium like, what are the risks for that person is complex, and the treatment is complex because there's multiple categories of problems to consider. So simply saying, this person's got a positive urinalysis, let's give them some trimethoprim, that's not enough. You need to say, is this person sad? Are they distressed? You need to say, are they constipated? You need to say, have they got optimal hydration? You need to say, in that list of 15 drugs, which ones can I reduce and which ones can I stop? You need to say, what is their falls risk? You need to say, are they at risk of pressure sores? You need to say, they're been sitting in this bed for 2 days. They need to get them out of bed, and so on. And so there's lots of things to consider. And sometimes one of the problems with pathways is because you have to consider these things in parallel, not necessarily in a linear order. So in Scotland, we developed the time bundle, which stands for Think, Investigate, Management Plan, and Engage, to try and structure the first 2 hours of care of delirium following diagnosis. One of the things I was really impressed about this morning was seeing from 2013, the delirium plan for Stanford, which includes showing videos about delirium to families and giving documentation. It's fantastic. That's actually rare. You know, in fact, engaging, telling families and carers about delirium is an unusual part of delirium protocols. And it's absolutely shocking that we don't make this mandatory, isn't it? Can you imagine one of your relatives, a vulnerable relative, having delirium, and how bad it's going to make you feel that somebody is clawing at things in the air, crying, seeing blood pouring out of the walls, seeing all those terrible things happening? Let me tell you a story about one hallucination, just to sort of bring this point home. This lady was sitting shaking, and she said that she saw dolls pinned all around the wall with white dresses and dark hair, pinned to the wall, all looking down at her like this. And in the floor in front of her bed, there were girls dressed in white dresses with dark hair who would be playing, and every so often they would stop and they would look up at her like this. And that happened all day. Isn't that horrible? So imagine if that's your relative and you don't know what they're, you've got come in to visit them and they tell you the story, and no doctor or nurse is coming to speak to you to tell you. You know, it's shocking that we don't say, this is delirium, it's usually reversible, this is what we're doing about it. And I saw that in action in the ward round this morning, just a clear explanation to the family. So that's a real strength of the program here, I have to say, but it's not universally done. So building on the time model, I thought to myself when I'm doing my ward rounds, I forget things. I sometimes have this kind of list of ideas about delirium treatment, but I sometimes forget things. So what could I do to help myself and remember the different aspects? So I'm going to go through these briefly in the next few minutes before I finish. This is just a set of categories of things to remind you about the things that need to be considered in delirium treatment. The first one is the patient sick? And again, as a physician, I'm quite surprised that a lot of the delirium treatment pathways start with look for causes, you know, without actually saying, well, is the blood pressure low? I mean, the sepsis 6 bundle, the CURB 65 score, lots of bundles say that if somebody's brain isn't working and the manifestation is delirium, then that's a sign that someone's prognosis is really bad or that they're very sick. We just did a systematic review published in BMC Geriatrics, which found that if you're drowsy as an acute hospital patient, the mortality at 30 days is 6-fold. So this is, you know, mental status change is a strong indicator of somebody potentially being sick. So the first thing you need to do is just the basic ABCs. You know, what's the blood pressure, pulse, oxygen level, are they retaining CO2, have they got low glucose, have they just had a massive dose of morphine that you need to reverse? Just that basic medical stuff is the first step, you know, when you pick up delirium, every time. After that, then there's a much more elaborate process involving looking at all the causes. And as I say, Jouko Lorla in Helsinki, he found that there are many different causes usually to consider, and often 2 or 3 in a given patient. Often the causes are fairly obvious, like a pneumonia or a urinary tract infection or too much of a certain drug. But it is something that does require analysis sometimes. If the first 2 days of treatment doesn't work, could there be a rarer cause? These are some systemic causes. And I think underappreciated, and this is maybe where geriatricians need to remember about primary neurological causes of delirium. And I'm not saying that delirium is the diagnosis necessarily, but it's the starting point. And I have seen a few cases of autoimmune encephalitis that have been presented as delirium, and they've been atypical delirium. They haven't responded to the usual analysis, and eventually the antibodies have gone off and they've come back positive, and that's been the diagnosis. I think sometimes small strokes can present as delirium, cognitive strokes, you could call them, and so on. As well as treating the causes and doing everything right, I think it's important to optimize conditions for brain recovery. Now, quite a lot of this could be what you do for acute kidney injury or many organ failure syndromes. Basically, you have to try and optimize everything. Some of these are just physiological things. But alongside all of that, there's all this business as well, which some of it is delirium prevention as well. I think mobilize is important too. Specifically, as I've said about that lady with the dolls and many other cases, we need to take time in a delirium assessment, not just do the cognitive assessment, but to say to the patient, how are you feeling? Are you feeling okay today? Are you scared? Is anything bothering you? If you find any distress and agitation, obviously this is very basic stuff, which I'm sure everybody here knows, but just go through the checklist of why someone's distressed and agitated. Try and treat the causes, but also specifically treat the distress. That could just be holding someone's hand and smiling at them and just saying, I'm here for you today, you're going to be okay. And actually that statement comes from a very moving story where there was a lady who tripped over a washing basket and broken her nose. And she unfortunately ended up in ICU with a pneumonia during the course of her treatment. She was there for a month. She had terrible delirium, and she often thought she was being killed. And she came and spoke about her experience. So one of her memories is that she heard some nurses talking at the door of her room, and they said, this lady's going to have a CTO. And she thought that means a compulsory termination order, which she thought meant she was going to be injected with a lethal dose of a drug and killed. So she had an awful time. And I asked her at the end of this testimony, was there any time that you felt safe, in your month? And she said, yes, there was one day that I remember. This is 2 years after. This is what a vivid memory this was for her. And this is very moving. She said, one of the nurses saw that I was very distressed, and she leaned into my ear, she held my hand, and she said, I'm here for you today, you're going to be okay. It's amazing, isn't it? That was just that one statement. That's all the nurse said, and was kind to her and smiled, provided reassurance. So that's why it's important to detect distress, because you can, as a human being, provide that warmth and reassurance to a scared person. And you don't need to reach for the haloperidol, necessarily. You just treat them like a person who's scared. And you need to go out of your way to look for psychotic features, because people hardly ever volunteer them. You have to ask about them using some of the kinds of forms of words here. Now, there are massive variations in how drugs are used in delirium treatment. I think in the UK, we're conservative and we don't really use drugs for delirium treatment very much outside of ICU. ICU, of course, is often necessary for safety reasons, but I would say I would use an antipsychotic drug in about 5% of delirium cases that I see. And I see a lot of delirium cases, at least 5 or 10 a week, and I have done for years. And I don't find it necessary to use more than that. I tend to use non-pharmacological methods, meticulous care of all the things that might have caused that delirium the agitation to come. But I do believe that there is a role for antipsychotics when you've tried everything, when the patient's scared at their wits, when they're psychotic. And I think small doses of risperidone, for example, twice a day for 2 or 3 days, then stop, is a reasonable thing to do. That's just my angle, though, and it's not necessarily evidence-based, because there's really no evidence outside of ICU. There's a bit of evidence of dexmedetomidine in ICU for prevention, maybe. Outside of ICU, there's really no convincing evidence that drugs are effective in delirium. In fact, if anything, there's evidence that they're ineffective and they cause harm. So I think you need a positive reason to use drugs. Certainly, as I mentioned earlier about a druggable target, if you give a drug like haloperidol, that's assuming that every single patient has got too much dopamine activity that you want to block. That's clearly nonsense. Many patients might have deficient dopamine activity. So that's a harmful thing to do for some patients. So you need a good reason to give drugs in delirium, a positive reason, rather than it just being a treatment for delirium. That just doesn't exist in medicine and medical research. It's not valid, in my opinion. Benzodiazepines are not good in delirium. They have a role where you can't give an antipsychotic, and when, again, there's a humanitarian concern or a concern. And I'm afraid the red doesn't really come out very well, but usually only 2 or 3 days of treatment is required. Should never be giving people 2 weeks worth of antipsychotics unless, there's really a massively good reason. I think by that stage you should be getting a senior experienced, a psychiatrist or someone who really knows what they're doing to say, are we justified in giving these drugs? In fact, I've often seen cases where haloperidol is causing the delirium, because what it's doing is it's impairing someone's ability to think, and they're unable to understand where they are, and it's making them weird. It's making them, Parkinsonian. It's making them fall. Their drives for eating and drinking are gone. It's a very powerful drug. So 2 or 3 days. Now, delirium has a lot of complications. These are some of them listed there. And this is why I'm saying that the treatment of delirium is difficult, because you have to think about all of those issues in a person with delirium in a systematic way, or you'll forget about it. So I think I've made this point very clearly, and I'm preaching to a converted audience who already do this, and in a very admirable way, in fact, better than we do it, because you have a video, which I think is a brilliant idea. But just a simple leaflet should be mandatory. In fact, we have something in orthopedic surgery called the family communication plan, which is like, when delirium appears in the notes, you must take positive steps to contact the family and explain to them what's going on. Monitoring for recovery is something that isn't really solved in the field, and I think it's helpful to know what the features are in a certain patient, so that you can say the arousal is improving or the psychosis is going down, and so on. Understand that happened this morning in the ward round. What do you understand by what's going on? If someone gets more coherent and they can tell you, that's helpful to monitor it. Let's not forget about persistent delirium. Around 20% of delirium persists for weeks or months, and it's a catastrophic failure not to recognize it. Sometimes people go to care homes because of persistent delirium, and their houses are sold, and they never go back home again. And sometimes they're better in 6 months. It's negligent, isn't it? That's a shocking thing to have missed. Sometimes you need to give someone time to get better. I'm aware of time, so I think I've made that point, but just the diagnosis is the critical thing. What is happening? If somebody was, a week before admission, was going to the shop to buy a newspaper, running their own lives reasonably well, or even in, some kind of facility but doing all right, and they're really different a month later, that's not dementia. It's not depression. That is nearly always going to be persistent delirium, and that needs a geriatrician or a psychiatrist like Jose, somebody who knows what they're doing, to come and work out why they've still got delirium and try and throw the full medical works at them to try and reverse it before they start to continue to decline and end up in a bad place. So there's very little evidence for this, especially outside of ICU, but in the field, most experts say that it's a bad idea to just let someone be immobilized and stuck in a chair when they've got delirium. And that used to be what happened. They just sort of got left, and the physio would come and say, they're not really complying, we'll come back tomorrow when the delirium is gone. Some form of activity I think is helpful, even just standing up a little bit, or some form of exercise and movement, just to try and keep that person as functioning as normally as possible. That's the principle. And Dale Needham, who's a famous ICU rehabilitation researcher, I'll just read this out. As we address delirium through better quality sleep and adjusted medications, additional physical and mental stimulation can make a huge difference. I've seen it happen time and time again. Now, that's not an RCT, but that is somebody who's done this for decades and really believes in it. And this is somebody who's intubated, being mobilized in ICU. So almost done. So many people with delirium also have dementia, especially older people. Some studies say around half of people with delirium have dementia, and quite often it's never been diagnosed. So it's a useful opportunity when somebody has delirium, if they're old, to think about whether they might have dementia. And obviously cognitive tests at the bedside during delirium, or even when somebody's recovering from delirium, are not going to give you an accurate picture of baseline functioning. So you have to use other strategies. Now, the informant questionnaire for cognitive decline in the elderly, the IQ code, or the Alzheimer's disease 8, the AD8, are both tools which involve asking an informant about how somebody's been doing up until the point of hospital admission, to see if there's been a decline over years. And they're both validated for use in hospital. This is quite a new set of insights, because it used to be thought you couldn't even give informant questionnaires in hospital, but actually it takes 5 minutes. Occupational therapists in my hospital do all the time, using the IQ code. If the score is strongly positive, consider working out some form of follow-up for that person, maybe in 3 months' time. Now, prevention, I think, is much better understood and implemented. I'm not going to say very much about it. It does work, and these are the kinds of things which have been shown to work. And I want to keep this quite simple. I'm not sure you really need some special scheme of prevention. I think this is avoiding iatrogenic harm. That's at least 2/3 of delirium prevention. Don't give them poisonous drugs. Let them see and hear. Keep them mobile. Don't allow constipation, dehydration. Keep talking to them. Try and keep them engaged. All of those things will stop the brain being harmed by hospital admission. And so having some kind of system to make sure all these things get done is a good idea, but I don't think there's much more to it than that. So the last slide of the talk. So everybody here knows that delirium is common. We know that it's very serious now from lots of studies, and it's a very distressing condition for patients and especially for families as well. I think tools to detect it and monitor it are useful and should be used. Don't forget that it's not just about diagnosing, it's about saying, what's it like for this person to have delirium right now? If I was sitting there in their bed, looking around with a strange person in a uniform, how would I be feeling right now in this weird place with tubes? And, you know, what's it like for that person? That's a very helpful thing to do, not just to be nice, but because it helps you tailor the treatment to that person. Don't forget that delirium is very complex to assess and treat, and 2 or 3 minutes isn't going to cut it. You're going to miss things if you do that. It takes time. And again, I'm going to back geriatrics again. I think, you know, geriatricians are the people who really understand all the medical systems properly and the interaction with frailty and what you can do in a judicious way with a list of 15 drugs and think about the impact on the patient's future health. It's a difficult thing to learn. It takes geriatricians in the UK multiple years to learn those skills. And the more geriatricians, the better to make a hospital run well, including you know, delirium care, I think is a reasonable principle. Keep the rehab going. And I usually really punch the last line here, but I don't need to do here because you're already doing this. And when delirium appears in the notes, tell the family. And the last couple of things are just to advertise some conferences. So the American Subacute Befuddlement Society is having its marvelous annual conference, wonderful experience of many leaders in the field from the US and internationally. It's a brilliant party as well as lots of peer support and plans get made over beer. You know, it's a great place to go. And I know it's quite far away from here, but do strongly consider, you know, trying to get leave to go to the Boston conference if you can next year. It's a wonderful experience. If you want to go further afield, there's the Australasian one in Melbourne in September, which I think there's even more partying goes on at the Australian one than the American one. And then Party Central for delirium conferences are the European ones. And my hometown, I'm hosting a meeting in September 2019, and I'm sure that all of these conferences will give a lot of information about the cutting edge of research, but also in best practice. And I'd just like to say thanks again for the opportunity to come and speak, and I look forward to hearing some questions. Thanks very much.
Thanks a lot. Trying to compress all of that in 45 minutes to an hour. Thank you. We'll take some questions now. Or we can talk. Any questions from anyone?
Just from your experience today rounding, I'm interested in your perspective of what you saw at the bedside and what the difference is from the nursing perspective as far as the interventions that nurses can do. Because I think of, you know, we see it as a problem and we can't obviously prevent this. So, you know, that's out there. We know these mechanisms of entry into the hospital. They potentially present with delirium in days, who knows many. But nurses have that impact at the bedside so often. So we often think, from my perspective, of what interventions can we do earlier, sooner, to really help with this that could be so meaningful.
Well, actually, it felt very familiar. You know, I thought that in the feedback when we were going around, the nurses who were giving very interesting and pertinent information about what the patient had been like with respect to agitation, eating and drinking, you know, and there was always, mobilization was on the agenda the whole time. So I have little to add to that. I just think that, you know, I think being person-centered about it, like trying to see it as a person who shouldn't be in bed at 11 o'clock in the morning, unless they've got a reason to be in bed, who should be eating. But it all came up, you know, and I think there's a lot of attention to that, which is really impressive to see, because when other places I visit, you know, around the world, it isn't always automatic. I think the one thing that's different culturally is the use of drugs. We use far less drugs than I've seen in Kaiser and here. I think there's a divide, you know, in thinking about that. And I'm not saying that I'm right and you're wrong. But I think the British are more conservative about the use of drugs. In fact, we're even more conservative than continental Europe. The Dutch use more drugs than us, we know that. You know, and we tend to see 2 days of risperidone, tiny doses, quite a big decision. Do you know what I mean? Like, should we deploy the risperidone? What do you think, guys? You know, and that's what it's like, you know, and it's like, okay, let's tell the family we're using this powerful drug that's got side effects, you know, and we would try, I think, really hard to do all the other things first. But I'm not saying that doesn't happen here. I'm just thinking that maybe it's seen as a second line thing, a drug, not a first line thing. That'd be the only thing. But I thought it was great, you know, and I think you're doing things better than us in some respects with the patient communication side.
Most of us, I don't need that.
I might need it though.
Most of the physicians who are treating delirium have choices that they like best for treating delirium. And I've seen this very common here. I don't particularly like Delta at all. I don't like it for no. It makes them do things they wouldn't want to do.
Yeah, but let me make it clear. Drugs are not a treatment for delirium. You know, delirium is not a condition that you treat with a drug. That's a nonsensical statement. You know, you treat distress within delirium or agitation within delirium, but you never would you say delirium, drug. And that's an absurd position. There's no evidence for that. There's no scientific sense for that. You know, we're not in a position where that is the case. I would say that there has to be a specific reason to use a drug, and it's when there's psychopathology within the delirium that you're treating. So the idea that you know, and I've heard psychiatrists say that. In fact, an Irish psychiatrist I know well has a belief that there's a biochemical problem in delirium common to all deliriums, which responds to haloperidol, and that everyone should be on a low dose of haloperidol. And that's just a belief. You know, it's not, I think when you're giving powerful drugs that have got side effects, you need to have strong evidence to use that in that way, I would say. Yep. And that's what we're trying to avoid. Yeah, and you see that because the doctor can write this drug, you know, and it's seductive, isn't it? It's seductive because it makes the patient better over the next few hours. It makes the nurses happier because there's no disruption. The patient might even like it, especially with benzos. But 4 days later, they're extremely confused and falling, and in the hip fracture ward with a broken hip, and no one's paid the price for that because they've never even seen it half the time. I think that's right. I think these drugs are powerful and they damage cognition. I mean, we know that risperidone, for example, makes MMSE scores drop. Okay, so you might be fixing the agitation, but you're actually making the cognition worse when you give an antipsychotic drug. Every time you give haloperidol, you make somebody less bright. They're less able to understand what's going on, even in delirium. Okay, so you have to have a good reason to use these drugs.
For years, I always told families, this is really scary, your loved one is totally confused, but it's going to get all better. Mm-hmm. And now I think with the recognition of some patients have persistent delirium, how do you message that to families? I've kind of pulled back of saying it's going to get all better.
Yeah, I mean, I think it does need a script. I think you're right to prepare for it because you're giving important information about somebody's future, aren't you? You know, it's not saying, you know, something that can be done casually. And I think pretty much is what you're saying. You just say, well, you know, 80% of the time this fully gets better. Some people it takes a few more weeks to get better, and unfortunately, we do know that sometimes not everyone gets back to how they were before. But we're going to try our best to try and deal with all the factors causing it. I think that's a more honest way of expressing it.
So, I just love your opinion on, you know, the exacerbation of the dementia symptoms or the dementia progression that happens post-delirium, post-hospital. So we followed some of our patients for a long time, and we found that, of course, the cognition got worse. And how do you message that to the long-term care facility, you know, providers or even family members, or in your, you know, experience being the expert, what else can be done? We understand prevention, we understand haloperidol, we understand all of that, but clearly, and a lot of the research papers have shown that, as you said, MMC gets worse. The general progression of dementia versus post-delirium and non-post-delirium, people who haven't had it is worse. Is there anything that can be done once they reach that setting?
I mean, that's a really interesting question. It's you know, burning issue in delirium, and in fact, there's just a paper come out from Vanderbilt and Pittsburgh trying to look at etiology of this presumed etiology of delirium and how that might affect outcomes. And it found, for example, that even what they classified as sedative-induced delirium was associated with bad outcomes. And it was only metabolic that didn't link with bad outcomes, you know, when there was some reversible metabolic problem. But sepsis, but what surprised everyone, I think, was that sedative-induced delirium. I mean, you can argue about whether it really was just sedative-induced delirium, but basically that argues again for conservative use of drugs, doesn't it? What I would say that there is no real evidence, but it makes sense to me that you give exquisite medical care to these patients. You know, you don't let the delirium, you know, fester. You don't let someone's blood pressure drop to 100 systolic for 2 days. You know, you don't let someone be hypoxic. You know, you give rapid, urgent, highly technical, highly efficient medical care, which is aimed at rapidly reversing the causes, getting somebody mobilized, returning to normal as soon as possible. That's all we've really got to recommend at the moment. But the old days when someone would just be confined to bed with a benzo, and you'd hope that they'd get better in 10 days, that's the sort of people I think come to a lot of harm because of the sarcopenia, you know, the altered balance, the psychological impact of a long hospital admission. I mean, somebody's often, especially if they've got a bit of cognitive impairment, they're really screwed up by that. You know, their ability to get back into their normal lives is affected. So I think it needs to be considered as an emergency. The longer someone's burning away with their delirium, the worse they're going to be it's like when I was a junior doctor and used to say they could predict the length of ICU admission by how long the patient had been hypoxic before the referral came, because of all the cellular damage and, you know, upset to that physiology caused by 3 days of pneumonia with a low blood pressure. And that's why the ICU physicians are running in and whacking in boluses of fluid and putting oxygen on, because they know that, you know, you're damaging the body a lot. And I think delirium is a bit like that. You know, you're really chipping away at someone's well-being for every hour they have delirium.
One of the challenge we have here that about the time of discharge of the patient from hospital to long-term facility and skilled nursing home. I mean, one of the big issues that we see, like the hospital, they discharge delirium patient, there is still, and then when the patient is discharged to a skilled nursing home, is a new environment, they get more delirious and they just return back again 48 hours again back to the emergency room, which has actually made it worse again. What about your I mean, the situation there? I mean, what is the timeline for discharging patient from the hospital? Because we always force by hospital discharge the patient as soon as possible, but there's still an acute phase of delirium.
Well, I think there's a good principle for saying that you need to get someone back to their home environment as soon as it's safe. And if that involves asking family members to come and live with them for a while, that can really turn things around, as long as the medical bases are covered. That's an argument for not using drugs as well, isn't it? You don't want to send someone home on haloperidol if you can avoid it. There's quite a bit of evidence now, that early supported discharge seems to help, but it requires a certain infrastructure and needs family education and support at home, somebody coming to visit. With respect to the change of environment and the cause of delirium, that's a very interesting thing, isn't it? We assume that change of environment causes delirium. Now, in terms of, Jose's scheme, that must mean that the stress of being moved, the fear involved in going from one unfamiliar place to another is causing some serious upset to the way the brain's working. We've all been jet lagged. We've all undergone quite a lot of stress in our lives with exams or, heaven knows what, but you can't escape stress. But it's never, I've never been delirious because of that. I felt bad. But, there must be something about being old and having maybe a bit of dementia, that being in an unfamiliar environment and the worry that induces and the fear and the uncertainty does something. Neurotransmitters go up and down, God knows what. So you almost can't escape it really. But I suppose there's interesting work by Christine Wazinski in Connecticut, where she recorded reassuring messages from family members on DVDs, and she played those messages during the day, and I think that was associated with less haloperidol use. So maybe it could be adaptive and adapt to that and say, well, we don't need DVDs anymore. We've got tablets or even big smartphones if the patient's vision is good enough, and just all the way through that they're going to the new place. I'm not being facetious, just sort of saying, it's okay, you're going to be in this new place, I'll come and see you later. That could really help, couldn't it?
Well, speaking of dehydration and malnutrition, we need to get you some lunch. But wanted to say a huge thank you to you for coming and for being our inaugural Grand Round speaker for geriatric medicine. And I'm glad we had such a wonderful turnout of people of all specialties, which is really wonderful.
Yeah.
And it was a great talk. Thank you very, very much.
We had about 20 people on.
All right.
Could we email Dr. MacLullich if we still had questions?